Hi guys, good evening. Dr. Jenny here, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall support group in aging adults, and geriatric clinical specialist. All right. So we are every Thursday, we call it Thanks God It's Thursday. We highlight innovators, academicians. We even have clinicians from Australia and UK at one point talking about different kinds of diseases such as different kinds of neurological issues that we as a physical therapists or clinicians work on how we can treat them. Innovators, different technologies. But for tonight, we will be talking about the different platforms out there and also about another neurological issue or disease that we can learn more using an app. So this is regarding DZDX. It's really very innovative because it's in one platform and we can learn more. This is really good to know because we don't know who is this for, how this it works, as a great clinician. We want always something in our toolbox. So without further ado, we have Dr. Nicole Miranda. She's a physical therapist, doctor of physical therapist, and she's based in Denver, Colorado. And she used to be treating different impedes brain injury, neurological diseases, and also in rehab institute. And with her experiences, we will tell her more about it and share us her knowledge. Welcome, Dr. Nicole.
Thank you so much, Dr. Jenny. It's great to be here with you this evening.
Oh, my pleasure. And I remember, Dr. Nicole, you're also a professor.
Mhm.
So, can you tell us more about what's your practice right now and how many years are you practicing or as a clinician? Thank you so much for the
Sure.
opportunity.
Yes. So I have been a physical therapist since 1995. So I'll just say the math is bigger than 25 years at this point. I don't count. So I go for those 5-year benchmarks at this point. So I have spent the majority, if not all of my career, mostly in neurological physical therapy, as Dr. Jenny said. And I started out in pediatrics and worked my way into more complex neurological conditions, and then ultimately moved into a private practice that focused on vestibular and balance disorders, in addition to all kinds of complicated neurological diseases and injuries. I think one of the steadfast things that's always been a part of my practice has been some form of brain injury or brain disease, and most heavily, especially with concussion. I've been very involved in concussion care throughout my entire career. And so that's really been my passion. In 2005, I moved a little bit into academia, but I officially moved into academia in 2018. And I currently work full time as a professor in a doctor of physical therapy program that's actually a hybrid accelerated model at South College based in Atlanta. So I live in Denver, but I teach from my house and I travel to Atlanta quarterly to do lab immersions with the doctor of physical therapy students.
Wow. Is it too far from each other? How do you balance those travel, or is it because more on the hybrid?
Yeah, it's not that bad because it's hybrid. The faculty travel in teams. And so the students are there for 3 weeks or so at a time, but the faculty come in and out depending on which class you're teaching. So you're never there for all that long. And it's actually quite fun. It's fun to be there for kind of anywhere from 2.5 to 5 days, depending on the course that you're teaching, and to be fully immersed with the students.
Yeah, I met majority now, more and more academicians in my practice. Just like you, I have Dr. Mars Beato, I have Dr. RV. Majority are now academicians, professors. What do you think, Dr. Nicole, will be a great character, or not really a skills, but more on what will be the key factor or key trait as a clinician versus if you want to go in an academician role or academic role?
Well, I think it requires a lot of clinical experience and background to be a good educator. I think you have to have been out in the trenches and met a lot of people and really learned how to build connections with patients, how to respect the way that they travel through the healthcare system, and really have the honor of walking alongside people in the healthcare system in order to really be an effective educator in the school to help prepare students for what it is. I think some students come into healthcare professions having had some personal experience or family experience where they've been fairly exposed to the medical field, and others really don't quite know what they got into until they get there. And so it's nice to be able to share clinical stories along the way. Students really thrive on hearing about clinical stories and look forward to their first experiences in the patients, interacting with patients in a clinical setting.
Yeah. So what's your challenges, Dr. Nicole, as an academician? So especially you're treating different students, different characters now versus patients.
I think probably one of the hardest things is to try to filter what you try to teach them. And so you can't teach them everything all at one time. You have to space it out and really learn how to teach down to the level of where they're starting and helping give them a really solid foundation so that they're equipped and skilled to be able to apply basic foundational information into clinical reasoning and to be able to really listen to their patients, to take in those very valuable stories, to be able to thread together what might have been, an underlying causative or reason for why someone is even seeing you to begin with, and how to build that trust.
Yeah, trust. And then because you will be like a mentor,
Mm-hmm.
the respect will be there. And I think you need patience. This is different. As a clinician, we need patience, but this is also another skills that we need to have. Be patient. And especially this is a learning process anywhere we go, right? Dr. Nicole, you talk about that you have experience in brain injury. So in PEDS, but it's still Neurological Institute. And throughout your course, what are the majority of your cases that you treat, knowing that it's a brain injury? I'm sure there's like a little bit more on like neurological, of course. So, but
Mm-hmm.
majority will be what?
So it's really been variable throughout my career, and I've really worked across the lifespan. So I've worked with anything from children to adults with tumors, with concussions, car accidents, random traumatic events that have happened to them, or even neurological diseases that are a little bit more progressive that aren't necessarily a brain injury per se, but cause changes in the way the brain functions and processes sensory and motor information, and just impacts their life and how they move and how they do their daily routine. My entire clinical career, I've always just enjoyed getting to know people and what it is they do in their everyday life and just how to help them kind of reconnect with themselves and figure out if they can't necessarily do all the things that they did before, what can they do or what could they do differently to re-engage with people and to kind of put some joy back into their life as they navigate a pathway.
Yeah, and we just recently we had a brain injury awareness week. So our
Mhm.
brain injury awareness month. So thank you so much for your service on that. And I'm learning and more because I am in acute setting right now and I'm seeing more. And it's really a big factor for me knowing that I always think brain injury is just TBI. You know what I mean? And then I thought stroke is stroke. And now I learned that it is an acquired brain injury. And
Right.
because only deeper people who's doing brain injury, digging it deep, will understand that. Because I know, oh, it's a cerebrovascular accident. That's a stroke. That's why you have certification for stroke. And then when I'm learning about brain injury specialization, that's an acquired injury. But I met lots of people now having dizziness, and you have this DZDX platform and I am doing this balance and falls prevention. So the
Mhm.
question is, what first begins? Is it falls? Do they fall because they feel dizzy, or do they have balance issues? So what comes first, Dr. Nicole? What's your thought about it?
Well, it's the chicken and the egg problem, right?
I cannot
So
answer that.
it goes both ways. I think that we see patients that come into the clinic with either a clear statement about a fall history or maybe a little bit of not ready to face the fact that they've had some trips and falls and they're a little bit more reluctant to tell us about it. Or maybe they're coming in because they are dizzy, but they haven't fallen yet but they notice that there's been a change in their balance and they're withholding from activities that they would normally want to do. Sometimes they might even feel insecure about driving into the clinic because they feel too dizzy, or they're not going to the grocery store because they're afraid they'll fill up their cart and then they can't get to the cash register to get back out to the car without having some sort of a dizzy spell. So I think one of the problems that we see across the lifespan, but more so in the elderly, is the risk of syncopal events or
Yeah.
passing out.
Mhm.
And with different changes to vital signs, blood pressure, different things as people age. And if the fall happens first and they even just mildly hit their head or don't even hit their head, and they just have what we kind of refer to as a deceleration event, they don't have to hit their head on anything, but that can still cause a little slosh in the brain that can result in a concussive event, even if it's very mild, which can then evolve into dizziness. And then if they're dizzy, they get more at risk of that happening again. So for some people, it can turn into a scary cycle of events. And then there's always unfortunate things that happen when people fall in places like bathrooms. We never like them to fall in bathrooms because there's too many solid surfaces that they can hit their head on. So that's what we see a lot of.
Yeah. And these are some of the examples of the dizziness cases that cause them some instability and falls. Do you have
Well,
other
it's
cases?
hard to know what the dizziness comes from. That's where
Oh,
you and I become a private investigator, and we have to help them figure out what it was that started it. Was it the dizziness that started it, or did the fall result in new onset dizziness that they weren't really having before, or maybe it changed the flavor of their dizziness?
mhm.
So I generally tell people that dizziness is a little bit of a trash word that doesn't have a good definition behind it. And so I try to help people come up with different adjectives to help describe for me what dizziness really feels like to them, and to give me examples of what it is that they're doing when the dizziness happens and how long it lasts, and whether or not they have any control on whether it gets worse or if they can calm it down.
Looks like with your experience, that's how you come up with the DZDX because of your students. Most probably you keep correcting them.
Actually,
So
there's a whole different story behind how I
go
came up
ahead,
with
Dr.
DPX.
Nicole. How did you come up with the DZDX? This is really
So,
platform.
unfortunately, my family has a fairly deep history with dysautonomia or autonomic nervous system dysregulation. And both of my children were affected in their teenage years, predominantly with difficulty with going to school because of dysautonomia, which is kind of what pulled me a little bit out of clinical practice. And so, at the time, I was teaching a lot of continuing education courses on weekends to therapists that wanted to learn more about vestibular interventions and concussion management. And so therapists started asking us, they would say, "This is so much information at the end of a weekend. I really want to know how your brain thinks through that whole pathway." And so while I was at home helping my children get their health back under control, I started mapping out how to think. So, and then I have a business partner, Heather Campbell, who's another physical therapist here in Denver. And so she and I got to business creating a thinking map about how to differentially diagnose dizziness, which then over a few years has become an app.
Oh yeah, that's really good. Yes, I met Dr. Heather in LinkedIn, so good to know. You're the co-founder of the DX. That's why you
Yes.
have Dr. Heather too. So it's always like that. There's something in the family, always that
Mm-hmm.
they are the reason why. We have many clinicians, their grandma fell. That's why they into in the physical
Right.
therapist. Some people they dig deeper more because of their son, and then so same thing with you. And then how does DCDX, Dr. Nicole, can help us clinicians or students in managing their patients? This platform, how can they help?
Yeah, so a lot of people think that they need to be a specialist to be able to treat dizziness. And there are certain people who do get vestibular specialization or a neurological specialization, and then they further specialize in treating dizziness disorders. But the research shows that only 30% of dizziness is actually related to the vestibular system. So there's a lot of other types of dizziness that people struggle with, and it increases as people age. And so if you think about when you look at just just prescription bottles that your patients have. One of the most common stickers on a prescription label is may cause dizziness. And so we see that a lot with medication side effects. I mentioned before, we can see it with changes in vital signs, with people being hypotensive or having just other changes in their daily management of their just regular vital signs of heart rate and rhythm and respiratory rate, of whether or not they're going through a viral illness, or maybe even sometimes post-surgical, coming out of anesthesia, people might have changes that result in dizziness. We also see a lot, again, of neurological degenerative disorders or progressive disorders like multiple sclerosis, Parkinson's disease. Lots of these different types of diseases have dizziness that go alongside them because our brain just processes information slightly differently. And our brain loves to create shortcuts, especially as we're aging. And we call those maladaptive balance patterns, where people kind of lock down and don't move as freely because they know if they make big swooping movements, they might lose their balance and fall. And so they tend to kind of keep all their body weight right in the center and kind of move more like a unit. And then when they get startled, they're more at risk of having a loss of balance or a fall because they've lost that really reactive dynamic balance. And so it's nice to be able to capture them in physical therapy to help try and restore those reactions. What the app does is it helps you take their history and the interview that you do with your patients about when and why they're dizzy. And then, as I said before, dizziness is a little bit of a word that doesn't have a lot of meaning. And so we have 12 different versions of dizziness in the app. Wow. And each one of those words, say, for example, lightheadedness or fogginess or head pressure, all of those descriptions of dizziness have common clinical patterns that might be associated with how someone moves, or if the dizziness occurs when they're walking versus when they're stationary, if it happens when they're getting in and out of bed. And so it helps them to make some decisions along the way about what that clinical pattern looks like. And then based on that clinical pattern, the app helps you with some hypothesized impairments and leads you into clinical tests that you would do to rule in and rule out different conditions. So I think what I hear a lot of times from people is clinicians feel overwhelmed by the amount of complexity that can be associated with dizziness. And so they don't quite know where to start and don't feel equipped with the ability to effectively help someone navigate that. But there also are not enough specialists around. So our idea with the app was to provide an online, freely available kind of on-demand app that you could use to be able to look into some of those things, like right at your fingertips, to be able to kind of help someone along that pathway. Mm-hmm. So that was the purpose.
Yeah, and I think this will build us more confidence, and because this giving us like a roadmap, like a more knowledge about this different kinds of dizziness that you're explaining. It's good to know that 30% are more in vestibular, knowing that we always talk about dizziness versus migraine, and we keep explaining, is your dizziness like, is it your environment moving around or you're moving around, and that's only one or two. How much more you just described that there are more. In your category, do you have the word woozy?
Yes, we do.
Because my patient we keep laughing every time you say, I feel woozy, and then, oh, woozy, and then that's her category. And all her family members always laughing when she keeps saying woozy, knowing that it's just merely dizziness, and then feeling off balance. That's why that's a woozy for her. So different term. So how can we connect, or how can we check this app, Dr. Nicole?
So the app is available online. It's at dizzydx.com. So it's dizzy and then the DX, like the abbreviation for diagnosis.com. And you can log into the app. We are actually in the process of putting up a 15-day free trial period, but it's also an annual subscription that you can purchase to be in the app. The annual subscription for professionals is $115, and then we have $49 rate for students and residents. And really what we found, we did a couple of beta tests with this, and we used it with students while they were on clinical rotations, and then they used it alongside their CI. And so it's a really good mentoring and training tool if you have, a lot of clinics have maybe one or two people that feel confident doing dizziness and treating dizziness. But when they go on vacation or maternity leave or leave to go to a different job, then the whole staff kind of has to shift and figure out like who's going to take on the dizzy clientele. And so it's really just to try and help give people more confidence and courage to help this population. There's 67 million Americans that experience dizziness annually just in this country. And so to be able to have access to value-based care, we all know as physical therapists how to observe functional movement. And we know how to ask somebody what happens when you move that makes you dizzy. And even if they need to go to an ENT or a neurologist or whatnot, you have skills that you can do to help someone dial back the intensity of the dizziness and to modify their movement patterns. If you can't get to a manner to stop the dizziness or to reduce it, you can help them adjust their movement patterns and maybe even help them cheat and move with that maladaptive balance pattern temporarily until you can get the medical care they need to then get them back and try to restore more functional movement. So, and then it's mitigating the fall risk, right? If they're dizzy and they need to get into a specialist, like, do they need to have a temporary assistive device just to make them a little safer until they can get more specialized care?
Yeah,
So,
so that's where your fall prevention assessment will kicks in, but there's always the history that I felt because I felt dizzy. And we
mhm,
can categorize versus the syncope. And then we can refer for cardiologists because this is something that is not merely vestibular because she passed out. Then we have many cases nowadays, syncope and then AFib, you know.
mhm,
And then these are the other categories of dizziness. It's my first time within 3 weeks that I have this vertigo. And she's learning the word vertigo because more people now is saying those description, but she's not familiar exactly what is it. Now, more
right.
people and even patients are learning more and more on what they feel. So it's really good to know that we clinicians will have these kinds of resources that we can help for us. So what will be your advice, Dr. Nicole, for the patient itself? They feel dizzy.
Mhm.
So what it's really debilitating, especially social. They don't want to go out anymore because they know they will feel dizzy. I just have an interview that brain, you need to shake the brain because the brain should be, and then that's why people are now feeling so dizzy because we are not really shaking our brain. Even the teenagers, they just look
Right.
their phone like this, and then when they get up, they feel lightheaded. So you're talking to a patient, what's your advice for our aging or older adults or whoever, different ages?
Yeah. So, I mean, just with any of our sensory organs, the old adage is if you don't use it, you lose it. And so, for people that aren't active and aren't moving, I mean, you guys have advertised all over the place the CDC guidelines of getting 150 minutes of movement, of exercise of some sort. And just how important it is to expose your brain to body motions. And Dr. Jenny, you're moving your head as you're demonstrating, but it is true. I mean, just even getting clothes in and out of the washer and the dryer and loading the dishwasher and carrying things around the house and just trying to challenge yourself especially if you're an older adult, to try not to do what we call the furniture surfing and touching things with your hands as you're navigating through the house and trying to work on posture and knowing where your body is stacked up against gravity. Gravity is not our friend as we age. Gravity kind of pushes us down and we adjust certain parts of our body. I always turn sideways when I say this. So some part of our bodies go forward and some part of our bodies go back and we kind of compress down with gravity. And so you have to find your new center. I describe it to a lot of people like when your car goes out of alignment and you take your hands off the wheel and the car veers, our bodies behave the same way. If we don't expose our bodies to a symmetrical movement pattern and kind of keep our bodies fluid and moving, then our bodies drift. And then we get all disoriented and we don't kind of know where we are and we withdraw and don't go out, like you're saying, Dr. Jenny. So I would say that if you're feeling that way, then to reach out to a local physical therapist and ask for help. Ask your doctor to refer you to a physical therapist if you live in a state that requires a referral. And if your physical therapist doesn't know a lot about dizziness, ask them to look at dizzydx.com and ask them to reach out to us for some mentoring, and we would be happy to help. So part of our mission is to really get help to out into rural communities where there are not specialty clinics, and to get resources out to clinicians who feel isolated, that have a lot of aging adults in their community that need support.
Thank you so much. Speaking on mentoring, and how can we connect with you, Dr. Nicole?
You can find me on LinkedIn, Nicole Miranda, and I would be happy to connect.
Yeah, watch out with Dr. Nicole Miranda, guys. We invited her to be one of our speaker for the Geriatric Rehab Summit. This is only 30 minutes and we learned a lot. How much more if we will get to know her, and she will going to prepare something for us and for the Geriatric Rehab Summit this year. All right. So any closing remarks, Dr. Nicole? Any advice for us?
No, I would just say stay in tune with your body. And if you don't feel clear headed, talk to people about why you're not feeling clear headed. You should wake up every day and feel like yourself.
Wow, that's really good. Especially now, it's also the mental health, stress related. These are all lots of factors adding it, right? And
Oh, yeah.
then especially just like not sleeping well, overload with the stress from work, you will have a headache, but you will be thinking you need to rule out, is this dizziness related to stress or something like that, the headache? Is this a migraine, what they said? So really, this is very helpful. We would love to learn more about DCDX. And especially, I think you talk about it, that it can be students, it can be in a hospital base, it can be for each clinician. So if we have any questions, definitely we will connect with you. So guys, if you are interested and you have any questions and you want to learn more about DCDX, connect with Dr. Nicole Miranda. We're going to put all her social accounts or LinkedIn information. Is email okay, Dr. Nicole? Yeah,
Sure.
we can put her email so that you can directly connect with her. She can even show you how you navigate the DCDX platform. It's easy to use, and it's just good to know that you have this case study like Mr. Smith, his symptoms, and then you rule out, okay, and then you keep ruling out, and then you left with this very high points case, and that will be your maturity of your diagnosis. And then that's how, and then even the interventions will be there. Imagine, so that will be very helpful for us, will be very effective. So thank you so much to Dr. Nicole, also Dr. Heather, for this amazing innovation. And guys, if you have any questions, connect with us. It's me again, Dr. Jenny Yusuf, physical therapist and doctor of physical therapies. I'm geriatric clinical specialist and certified exercise expert in aging adult. I'm the recent state ambassador or advocate in geriatrics. But now I'm looking forward to learn more about neurological and brain injuries. So connect with us, all right? And thank you so much, guys. God bless. Thanks, Dr. Nicole.
Thank you, Dr. Jenny.